Assalamu alaikum. The short clinical day. We'll start with the cardiac station. So you examine the cardiovascular system.
Okay.
Dr. Maida, just give her the patient presentation.
Okay. 57 years old gentleman presented with examine his cardiac examination for this gentleman, and I will tell you the positive sign.
Okay.
Hello, good morning. My name is Dr. Marwa, one of the doctors in today. I'm going to examine you. If you feel any pain or discomfort, please let me know.
Okay.
I will take 2 steps backward and looking for the surrounding and general condition of the patient. Any abnormalities?
Okay.
Any surrounding?
You tell me, what do you want to see? There is nothing in surrounding.
Patient also make comfortable in bed.
Yeah, orthopnic.
Okay. I will ask the patient to expose the chest. His chest. I will see if any scars, any abnormalities in the chest.
No scars.
No scars. I will see the lower limb for scars also, and I will examine the pulse and edema at the same time, and see scars.
Both and
edema, lower limb edema.
Okay. There is lower limb edema.
Bilateral beating.
Between bilateral up to the shin.
Okay. Then I will go to the patient, examining the hand, dorsum for any clubbing, splinter, hemorrhage, cirrhosis, and palmar for any palmar erythema or.
Palmar erythema. Nothing in the hand.
Yeah. I will ask the patient to extend the hands for looking for any tremors.
No tremors.
I will examine the pulse for the rate or rhythm or equality in both sides.
Okay. High volume pulse.
Regular or irregular?
Regular.
Equal in both sides?
Equal in both sides.
I will examine for collapsing pulse. I ask the patient if there's any pain in your shoulder. If no, I will elevate the arm and examine for the collapse. Wait for a while and examine the for collapsing pulse.
Yes, positive collapsing pulse.
Then I will look for in the neck for any for examining for jugular venous pressure, raised or not raised.
Sorry?
Jugular venous pressure raised or not
Which
raised.
one?
Jugular venous pressure.
Yes.
Raised?
Yes, raised. Yeah.
طيب okay. I will ask the patient pull down his eyelid, looking for any pallor or jaundice.
No pallor.
Ask the patient open his mouth.
Some pallor, but no jaundice.
Open the mouth for any abnormality, gingival hyperplasia, any abnormality in the mouth.
In the mouth, no abnormality you can detect.
Okay, I will palpate chest for side of the apex and the character of the apex.
Okay, what do you think? Then displaced apex.
Displaced downward or outer side?
Yes. Down.
Both?
Down and downward and outward.
Okay, I will palpate for for second palpable heart sound and illustrates in the four areas that thrill and a second palpable heart sound,
Yes, palpable second heart sound.
but no thrill.
Not, you know,
Thrill.
thrill. Yeah, there is thrill.
Yes. Where?
In the second aortic area.
Second aortic area.
Yeah.
Okay. I will auscultate apex
Mm-hmm.
for any murmurs.
Yeah, there is murmur.
For character, systolic, diastolic, character.
Yeah, you can tell. What do you think it will be?
I think it is early diastolic, aortic regurg,
Mm-hmm.
early diastolic now.
Mm-hmm.
I will.
Describe the murmurs.
Diastolic, early diastolic murmur increase with expiration. Radiated, maybe radiated to the carotid or not.
Mm-hmm. Okay.
I will examine the apex in the lateral position also. Then I will auscultate the tricuspid والpulmonary والfirst aortic, second aortic. Then I will ask the patient to sit down and will auscultate for second aortic and first. The first aortic. Can I read first aortic? The third intercostal, third left intercostal. And ask the patient for leaning forward for any murmur.
No murmur. Mm-hmm.
No, I think I finished this expedition or not.
Finished. Okay.
Finished, huh?
According to you.
I think I finished.
Okay,
I don't remember anything.
no problem, Dr. Mara. You finish. What you want to do before going to the examiner? If you finish.
I want to complete my examination. I would like to do the radiofemoral delay
Okay. This is
blood
for
pressure.
you. Okay, this is for you. What about the patient? For patient, what you want to do before moving to the examiner? What you want to do?
Thank him.
Exactly.
Give
Cover.
the chair to cover.
Okay, cover patient. Thank you. Okay, now the examiner question, Dr. Maida, please.
Can you present your case?
My case is 57 years old male patient presented with shortness of breath. On examination, there's the apex is displaced in the sixth intercostal space in the mid axillary or axillary line, and according to the side, there is early diastolic murmurs, here the best hearing in the second right intercostal space, increase with expiration. Also, there's lower limb signs of heart failure in form of orthopnea and lower limb edema. I can't detect any signs of infective endocarditis. Also, there's signs of pulmonary hypertension, second palpable heart sound, and thrill. This case of aortic regurg complicated by heart failure and heart failure.
Okay. Did you examine the base of the lung?
Yes, I forget this. I forget the repetition, so it's just
Do you examine GVB?
I examine GVB raised also.
Yeah, you examine. Okay. So what is the differential diagnosis? You said this patient has a aortic regurg, yeah? What the etiology of aortic regurg?
Maybe congenital or rheumatic or congenital أو rheumatic أو complicated infected endocarditis or after or part of ankylosing spondylitis يعني autoimmune disease أو connective tissue disease part of connective tissue disease.
ماما
Okay.
ممكن تسوي تاني
Okay.
other differential
Okay. So how you'll investigate this patient?
I will do bedside test ECG و echo. I will do the basic investigations, CBC, liver, basic liver and kidney function. والchest X-ray. And according يعني the cause we searching for the cause if ankylosing spondylitis MRI vertebra أو also الناتريتك بتاعت for heart failure والelectrolytes chest X-ray.
Anything else?
Investigations.
Yeah. Okay. How you manage this patient?
I will admit this patient because he is in heart failure. I will include the cardiology team and chest doctors and cardiac doctors. Stabilize the patient, maybe give the diuretics for volume because he has have water retention volume overload. And after echo, we'll assess aortic valve condition if need surgery or repair.
So what is the indication of surgery in aortic valve in aortic regurg?
Indication of surgery. Parameters كده but I didn't remember any parameters. I can't remember.
Okay. Do you add anything? Can you describe the pulse?
البلس large volume pulse with large volume with collapsing pulse. Regular equal in both sides with collapsing pulse. والإيبكس قلنا displaced والميرمرز الإيبكس والميرمر والبلس.
No, describe the pulse. I said.
أيوة.
Describe the pulse in this patient.
Large volume pulse, regular, equal on both sides with collapsing pulse.
Okay. Did you examine for the Corrigan pulse, pulsatile pulse in the nail?
No, but I should.
Did you examine for the head node popping with heart?
Signs of aortic radiation.
Yeah.
Hyperdynamic circulation.
Yeah, and you have the pistol
shot.
Doroses, mermus as well. I think you examined for the mermus anyway.
Okay.
Mm.
Yes. So you can comment now, Dr. Maida. Finish the questions. Any other question you want to add?
No.
Okay, you can comment now about the performance, then about the topic itself.
Yeah. Before that, I think just to complete the question, come with this topic.
Yeah, no problem.
Okay. So if we start that this patient have a high volume pulse, can you give a differential diagnosis of hyperdynamic circulation?
Hyperdynamic circulation maybe include aortic leakage, hyperthyroidism, fever, pregnancy if female. Maybe pulmonary leakage, maybe.
Which one? Sorry.
Pulmonary leakage. This is what I remember. The thyrotoxicosis, fever, pregnancy, aortic leakage.
Yeah. Okay. What's bone disease can cause a hyperdynamic circulation? Do you remember any?
Bone disease? I mentioned ankylosing spondylitis if associated with aortic leakage.
Which one?
Ankylosing spondylitis.
No. Another one. Bagged disease. Bagged disease also will be associated with hypo.
With
hyperdynamic circulation.
Due to what?
Because bagged disease itself, hyperdynamic circulation, arteriovenous something, I couldn't remember, but one of the manifestations will be hyperdynamic circulation in bagged disease. Okay. So generally, you did well. That's you start first. The case is aortic regurgitation. You start by introducing yourself and identify yourself to the patient and take permission and everything. You understand that this patient have hyperdynamic circulation. You know about the pulse. The only thing that you need whenever you detect that this patient has high volume pulse with collapsing pulse, you need to look for other sign of aortic regurg peripheral pulses, like as we said now, the Corrigan sign, pistol shot, and all this sign. Then you said that this patient, you examine the lower limb and you find that this patient had bilateral lower limb edema. So this patient most probably in heart failure. Patient in heart failure, you need to complete your examination by examining the back for edema as well, and to examine the bibasal crackles for this patient. The good thing that you look in the hands for sign of infective endocarditis, because one of the chronic aortic regurg cause is congenital, is infective endocarditis as a cause. So this is important that you did this examination. Regarding the cause of aortic valve regurg, also we have like Marfan syndrome, Ehlers-Danlos syndrome, aortic aneurysm, syphilis, and ankylosing spondylitis. So this is the causes of aortic root cause of a aortic regurg. I think if you divide the causes, the etiology of aortic regurg to acute and chronic causes. So acute causes can be infective endocarditis. Maybe the patient have aortic dissection, trauma, prothetic valve dysfunction. This is the acute cause. And the chronic cause, we can say like valvular causes and aortic root cause. The aortic root cause, mainly, this is the connective tissue disease, Marfan, Ehlers, and syphilis aortic disease. Then the valvular disease will be a rheumatic heart disease, congenital bicuspid, infective endocarditis, and myxodematous degeneration. Okay. Regard investigation, I think the investigation, very importantly, patient with any heart problem, you need to do an ECG, you need to do an echo for him, yeah? So you did an X-ray, you did chest X-ray, and you did basic investigations, but you didn't do an echo for the patient.
Yeah, I mentioned echo and ECG. I mentioned first thing ECG or echo.
Maybe I didn't hear that. Sorry. Then we can do cardiac MRI and cardiac CT scan as well, if we want to go further for that. The treatment can be medical treatment or a surgical treatment. So the indication for surgery, that if the severe aortic regurg with left ventricular dysfunction, that means ejection fraction is less than 55%. This can be indication for aortic regurg. For medical treatment, normally we give, it's a treatment of heart failure, that by giving vasodilators with AC inhibitors, and we treat underlying cause if there is any underlying cause. Normally in the aortic regurg, we avoid beta blockers, specifically in acute aortic regurg. Because I think it slows the heart rate and worsening the regurg as well. Otherwise, I think you did very well. Nothing this is all. About hyperdynamic circulation. So when the patient have hyperdynamic circulation, the things that fever, anemia, hyperthyroidism, pregnancy, exercise, and sepsis, this is the first one. Aortic regurg second, and BDA also can be one of the causes of sign of white pulse. Also arteriovenous fistulas, and also we have thiamine deficiencies. Thiamine deficiency also associated with bounding pulse. Paget disease also associated with a wide pulse. Because I think they said that there is arteriovenous shunt in the bone, and this is increase the cardiac output. This is all.
Acromegaly as well, you can add it to them. As cardiac output failure or high cardiac outputs. Okay. Yeah, well done, Dr. Marwa. Thank you, Dr. Maida, for your case. I think Dr. Maida covered the case well, but Let's arrange the answers, Dr. Marwan. When you are stuck with the pathology, just remember, as Dr. Naida said, you can divide your answer to acute or chronic, or as in the aortic stenosis, you can say supra and aortic. But here you will not say subaortic. You can say the supra-aortic or supravalvular, sorry, and the valvular at the level of the valve and post or above the level. And
But
you can remember.
classification, this
Yes.
classification in stenosis or in regurg also?
Yeah. This is for stenosis. But I mean here, you can remember the cause of aortic root dilatation.
Mm.
You can enumerate all of them. It can lead to
Mm.
aortic regurg, plus the
Mm.
aortic, the valve itself. So the aortic
Okay.
root as a cause, it's common, very common. Most of the disease associated with aortic root dilatation will lead to aortic regurg, right? So
Yes.
you can remember them, like Marfan or Ehlers-Danlos or any collagen disease can lead to the same. Plus the valve itself might be wide or regurg. Let's go to the other causes. As Dr. Maidi said, the valve itself. So what will happen on the valve, for example, infection or congenital since birth or trauma, aortic dissection, all the things might be as causes. But don't stuck, oh, I forget or I cannot remember. You can just divide and give him the common cause. What you mentioned is good. Also, you can say congenital and acquired. It's good classification. You can say yes, congenital patient already born with this congenital disease, heart disease, or it might be acquired like trauma, like infective endocarditis, okay, or collagen disease, or aortic root dilatation, trauma, like this. For what you said also, I cannot remember now. I think the causes. Yeah, yeah,
الكرايتيريا for surgery.
yeah. The indication for
Indication.
surgery,
Oh, the
exactly.
indication for
Yes. Always for all valve disease, all valvular heart disease, if you mention symptomatic patient, you will be safe, whatever the symptom he has. So this patient, for example, if he's severely dyspneic because of aortic regurg, this is indication. Infective endocarditis, it's an indication as well for surgery or intervention. Plus some echo finding. By the way, you can mention these answers in any valvular heart disease. Echo finding, this is there is criteria, of course, but even if you cannot remember the numbers, the gradient, you can mention there is echo criteria. Some of them, the examiner doesn't know the whole details or the all indication by echo. And infective endocarditis itself, valve already damaged, or the indication of infective endocarditis for surgery, the non-response to medication, abscess, the culture, atypical culture, and so on.
But في
The
اي سي جي تشينج في اي سي جي تشينج في الانفكتيف اندوكاردايتس مع الاورتيك روت قد ايه؟
you mean PR interval increased? PR interval? This is with aortic root abscess, you mean?
aortic root abscess.
I'm not sure if some cardiology or someone in the have cardiology background who can inform us. Anyway, in general, you can say this answer. So infective endocarditis, symptomatic patient, of course, on the top, the symptomatic patient who is coming with severe symptoms of heart failure, aortic regurg, and blood pressure is not maintained. There is a lot of complication. You can mention this indication for surgery. Heart failure, of course, one of them, and the infective endocarditis and aortic root dilatation. There is criteria for aortic root dilatation itself. For example, with Marfan syndrome, more than I think 4.5 for Marfan is indication for surgery or intervention. For regular patient or non-Marfan patient, or 5.5, sorry, 5 and 5.5, right? 5 millimeter.
Marfan less than normal. صح؟
Yes, Marfan
فالمرفان
more,
less
yeah, the
less
threshold is lower. Yes, exactly.
less
The threshold, yeah, so 5 millimeter, more than 5 is indicated for surgery. And that's why they have also screening for his aortic root. For other patients, 5.5. More than 5.5 is indicated for.
دكتور باسم بس مشان
Yes, Dr.
الثresholds
Hans. Yes.
من ثلاث أرقام صح كلامك 5.5 normal population بعدين المارفان بينقسم لقسمين with family history without family history with family history عند 4.5 تمام without family history بتستنى ل5 ونورمال population 5.5
Okay, perfect. Thank you, Dr.
يعني
Hans, for
أربعة
that.
ونص
Yes,
أربعة
yes,
ونص 5 و5.5
yes.
يعني هن ثلاث
Perfect.
أرقام
Yeah,
ورا بعض 4.5
exactly.
مارفان with family history of aortic aneurysm rupture يعني عنده sudden death عنده complicated family history فهذا ما بتستنى عند 4.5 you operate مارفان without family history of vascular complication عند 5 normal population
Yes.
عندهم sporadic cause of aortic aneurysm أو آسفة يعني aortic root dilatation عند 5.5
Okay. Thank you, Dr. Hans, for that. Yes.
العفو الله يسعدك
Okay. This is regarding the pathology indication for surgery. The management already explained by Dr. Maida. The diuretics is the cornerstone of the management of aortic regurg. Diuretics, so especially or particularly the patient with heart failure. Plus the indication of surgery we already mentioned. Don't forget for the infective endocarditis, if there is possibility, the precautions for infective endocarditis. So it's another. You can take the examiner to this point, the infective endocarditis and the management of infective endocarditis, either indication or the precaution, the prophylaxis, and so on. The option for surgery also is important to know, particularly the young or elderly, how to operate. We should know the options for the surgery, replacement, or TAVI. This also other options and other questions in the aortic regurg. Okay, one more thing I want to add for Dr. Marwa. Yes, don't forget the back examination in the aortic regurg or any heart disease. Back for sacral edema for bibasal crackles. You have to examine, okay?
Yes.
I think this is the topic. Anyone want to add comment or suggestion for this topic? Okay, I added some comments in the chat box. Pulsating jugular vein. Whenever you have raised GPP, so you have to comment if there is it pulsatile or not, or pulsating or not. What do you think the importance of pulsating? Sorry?
I would like to just to introduce a case, يعني comment by yourself and introduce
Yes.
this case by what's the ideal introduction.
Okay, go ahead, Dr. Goda.
لا, for you, I want to listen from you how to ideally represent the case, this case.
Yeah, you want
طب
presentation of
هسأل على
aortic regurg?
Yes, this
هسأل
case,
على
how I can
هسأل على
represent
حاجة
the
في
case.
الجي في بي هسأل بس
Okay,
على الجي في بي قبل البرزنتيشن في الجي في بي
okay,
لو احنا
yeah.
شفنا لقينا الهاي جاكولار فينس في الانسبكشن بس بنعمل بريشر على الرايت هايبوكوندريم برضو ولا ما فيش داعي؟
Yes, you can press because sometimes it's not raised and you should put the patient in what level?
if raised
Semi-sitting.
يعني if
If
raised
raised, if raised, it's and more than the sternoclavicular angle level, so no need to press. It's already dilated and pulsatile, for example. But what are the causes of pulsatile GVP? Do you know?
No.
It happens usually with tricuspid regurg. And sometimes also you can hear the parasternal regurg. So a murmur, I mean, murmur. You can hear a murmur in the tricuspid area, right?
يعني
I'm not sure if there is patient or scenarios of tricuspid regurg. I think we have some cases in Egypt, tricuspid regurg. There is, I think, but I don't know in basis wise. Anyone faced tricuspid regurg as a cardiac station?
usually ما بيجي لحاله، بالعادة بيجي functional، بيجي مع البلمونري hypertension. تمام.
Okay.
أو بيجي
Mhm.
مع الكور بالمونال، يعني بيكون في عندك pulmonary hypertension وعامل لك right side
Yes.
heart failure، فبيجي حتى بيسموه functional tricuspid regurg. تمام.
Mhm.
فبتسمع الميرمر بنفس السكند aortic area اللي هي أصلا الترايكاسبيد area. بتسمع التي ار على انه سيستوليك ميرمر، وبالعاده
Mhm.
بيكون في معه بقيه الباكج اللي هي حتى جي في
Loud
بي،
B2.
لور لمب اديما، بالسيتايل
Mhm.
ليفر،
Mhm.
اسايتس. تمام.
Mhm.
فممكن طبعا تلاقي باي بيزل كراكلز، وممكن ما تلاقي على حسب اذا هو باي فنتريكولر ولا بس رايت سايد. تمام.
Exactly.
فما كتير
Yes.
تعتمد على الباي بيزل، الباي بيزل
Yes.
فريكلز. فاغلب الاحيان الترايكسبيد ما بعرف، انا بتذكر مره قالوا انه اجت بانفكتيف اندوكاردايتس،
Exactly.
لقوا
Yes.
البيشنت على انتي بايوتيك، وكان عامل تاتوز وعمره صغير ونيدل شيرينج، وقال لك اجت
Exactly.
tricuspid regurg as a sign of right side heart infective endocarditis precipitated by
Drug
needle
abuse.
sharing أو
Yes.
tattooing أو أي risk of acquiring bloodstream infection. وإنه كان الكلوز بيشنت على antibiotic ومبين sick ونحيف وحاطط
Mhm.
tattoos، ويعني he is this kind of
Yes.
people who you can expect such a risk factor. هي المرة الوحيدة اللي بتذكر. وبيحبوا
Yes, I
يسمعوا
remember this.
الترايكاسبيد ريجيرج بالكارسينويد وبالنونان.
Yes.
فهل اجوا بقى ستيشنز؟ ما اجوا، لكن يعني very
Yeah,
rare انه تيجي
I think
بهالطريقه
I think
كارسينويد نونان infective endocarditis functional.
yeah, I think Dr. Hind, it was a long scenario, not long
النونان
consultations.
اعتقد كانت لونج، انا معك.
Yes.
بس يعني اذا اجاك بيشنت
And
كاردياك وهاز الديسمورفيك فيتشر مثل المورفان، تمام،
yes.
فبقصد انه we encountered الترايكاسبيد ريجيرج بهالسيناريوز، لكن اللي اجوا بالامتحان 90% functional، أغلبهم functional. ما كان في حدا، أولا ما كان السيناريو isolated tricuspid
Mhm.
regurg، يعني أنت في عندك valvular abnormality أو pulmonary hypertension، عندك قصة تانية tricuspid is a part of the complication.
Yes.
تمام. you can يعني mention it as a part of complication. ف it never came، يعني it's very rare إنه يجي isolated، و it's very
Isolated.
rare إنه يجي part of other systemic disease.
Yes. I think it was a case in the long clinical consultation as acute infective endocarditis with tricuspid regurg. Yes.
انت قصدك
It,
حتى تبع الانفكتيف اندوك، انا سمعتها
yeah.
والله انتي
And
بايوتيك
long. Yeah.
وانسبكتنج السراوندينج، فبتذكر انه كانت
It was
كلينيكال،
long also. Yeah.
بس
Long
ميبي
clinical.
كمان
Yes.
اجت لون، لانه كان كاتب انه فتت وما يعني ما بالعاده نحن اذا في كانيولا وي تيك كير اوف ات، ومن بعدها خلص، يعني انه any patient on
Mhm.
antibiotic think of infective endocarditis. بس يعني الواحد to take care since it came they can
Yes.
shift switch the patients وهكذا.
Exactly. Yes. Thank you, Dr. Hind.
العفو.
Let's talk. Yeah. Thank you. Let's talk about the presentation Dr. Goda asked. So I prefer Dr. Goda to present as what you examine in the steps. So first, you are examining at the end of the bed, right? You take, as Dr. Marwa said, 2 steps backward for the surrounding, for the morpho, any shape change, any dysmorphic change or characteristic fascia. So this would be the first words to present. Plus the patient look, how he look. Is he distressed? Does he have any tachypnea, dyspnea? So this is what you will start presenting with. So I examine Mrs. X. He looks comfortable in the bed. If there is surrounding, you can mention there is surrounding. I prefer to start by this way, the inspection. Why? Some finding or some inspection finding, it's important to be heard by the examiner. Maybe not in the cardiac station, maybe in the neurology, like wheelchair, with stick, walking aid. Why? Because if you didn't mention it earlier, you'll forget it. And it would be very important to be heard by the examiner. He will give you marks on this, maybe more than the neurological examination itself. Okay. So let's start, as I said, commenting about the surrounding and proceed the patient looking distressed or orthopnic, as in this scenario. Try to mention the words related to the case. So if you say this patient looks orthopnic, you want to say he is in failure, right? Or he's having heart failure. But this is by general look. He's lying flat, but he looks orthopnic. Sorry? Okay.
Maybe on oxygen also السراوندي كان
Perfect.
نلاقيه على
Yes,
oxygen.
perfect. Maybe beside him, as Dr. Marwa said, there's oxygen, nasal cannula, simple face mask, even oxygen without using it. You can comment. You are here examining the patient and the surrounding related to the patient, not only examining the patient. So you can say, as Dr. Marwa said, plus some cannula, fluid, anything related to the patient, you can add it initially. I can see this patient orthopnic, he's on oxygen. There is oxygen cylinder, there is cannula, there is anything related to the patient you can comment on. This is by inspection. I prefer after that you can comment like peripherally and axially. What peripherally I mean here? The hand examination, clubbing, cyanosis, any infective endocarditis signs if there is, and the pulse. All these are peripheral signs. The pulse volume, the character, regularity, and there is collapsing pulse or not. This is before also I go to the cardiac presentation or the chest presentation. I prefer to do in this. Peripherally also you can add there is harvesting scar in the lower limb if you find earlier. And I believe you can do the lower limb examination while you are standing at the end of the bed. So let's start. A patient looks, I examine Mrs. X or Mr. X. He is orthopnic in bed or he's comfortable, whatever. Then I examine his hand. The pulse was regular, 80, you can say a number regular and symmetrical. He has collapsing pulse, for example, if there is. If no, you can say no. If there is infective endocarditis signs, you can add it earlier as well. If not, delay it till the end. Okay, we will not mention it early. So you are presenting the positive only, the pulse, the number, the regularity, symmetrical or no, the collapsing pulse. I notice he has now, I'm going to the chest and the face. He has raised GVP, pulsatile or no, and he has, for example, if there is cyanosis, central cyanosis or no gingival, anything positive, mention it. If not, skip it. Okay, jaundice, pallor, nothing. You can now start examination, presentation of the chest. I noticed there is a scar or no. For example, if this patient, I think no scar was here, so I will not say there is no scar. I will not say it. What I will say the positive finding because they don't want to hear no, 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 no. They want to know the positive finding. So I will say there was a displaced apex. No mention, no need to mention is it axillary. It's displaced outward, downward. You can, if you are sure it is in axillary line, okay, you can say. But if not, you can say this only displaced. No special character over the apex. Then now I will go to, this is by inspection and palpation. Now I will go to the auscultation file. If there is thrill, I will mention, of course. If no, skip. The auscultation, I can hear early diastolic murmur over the second aortic area in the third left intercostal space, more in the sitting position, and increased by expiration or exhalation. If there is a radiation, you can say. If no radiation, no, don't mention. Okay. So this and you can before suggested the diagnosis, you can add now. I couldn't appreciate any signs of infective endocarditis. Here you will say there was failure symptoms or signs of heart failure, right? As Dr. Mimay said, there is bibasal crackle. So you can mention it before ending the closure of the case. So before I will summarize, I will say there was bibasal crackles and sacral edema. But if not, we will skip it. Again, let's say I would summarize this patient is having features suggestive of aortic regurg in the form of 1, 2, 3, and I couldn't appreciate finding of heart failure, signs of infective endocarditis, or pulmonary hypertension. I think this is the most accurate and perfect presentation, what I prefer and in my opinion. And everyone he has his approach. Follow your approach. If you are already trained on some approach, no need to follow mine if you are not comfortable or not satisfied with this. But I think this is yeah, Dr. Good.
سألتك مثلا يعني the common question, what is the sign of severity of this aortic regurgitation? Clinical sign of
Severity,
severity.
symptoms, symptomatic patient, right? Heart failure. Patient might be present with a heart failure. And the scales of heart failure, NIHA score classification. This is the severity, right? And
Yes.
there is echo finding severity. Echo, the gradient, for example, or the valve area itself. By the way, I'm not talking about particular disease. Any valvular disease, you can mention this answer. The severity of aortic stenosis, the same. Symptomatic patient will present with symptoms or echo finding, like the surface area, like the gradient between the valve, like
I mean the member itself and the galloping and these things, portal hypertension, pulmonary hypertension. This also the signs of severity.
I think
complication.
also the Carrigan sign is a sign of severity, wide pulse
Yeah,
pressure.
this should be mentioned, all of them, if there is in the patient. These signs you have to mention it. Pulsatile nail, for example. I talk in general, but if you want to specify presentation of aortic regurg, you have to specify the finding of aortic regurg. I could say I could appreciate signs of pulsatile nail, Corrigan, right? Demostate or head nodding. If there is, of course, pistol shot, and you should do it, don't mention it unless you examine it. Or you can say, I would like to check it if you didn't have the time to do it. But there is, of course, signs of aortic regurg, you have to mention them, if there is in the patient, I mean. Okay. Someone was talking about the signs. Who was? Dr. Ahmed?
Yes, like wide pulse pressure, Carrigan sign,
Yes.
demosate, what you mentioned, and these are signs of severity.
Yes.
Yes.
Okay. Anything still missed? So the white pressure, the pulsatile nails, demostate, pistol shot.
The most
Anything
also water hammer pulse should be during examination to raise the hands up
Yes,
after
collapsing pulse,
intubation.
yes, also.
After
collapsing pulse?
intubation, if you
Yeah.
have pain in your shoulder, then I elevate the arm up to
Yes.
detect the water hammer pulse, which is important.
Yes. Yeah, you should do it, yes. And it will be presented, by the way, in the presentation. He has collapsing pulse, for example. I mentioned the pulse character, the volume, and the regularity, symmetrical, and the collapsing pulse in the forearm, for example, bounding pulse or collapsing pulse. Okay, you can present them earlier in the peripheral sign. Plus, aortic regurg signs itself supposed to be mentioned in every area, like the hand, the nail is pulsatile in the hand, the demostate in the neck, so you can mention it while explaining or presenting the neck finding. Raise GBP, and also I can notice head nodding or demostate sign. Okay, but aortic regurg is not common like aortic stenosis and mitral regurg, but it comes. So you have to be ready. But the most common in cases wise, aortic stenosis and mitral regurg. This is what I realize. Sometimes they are also bringing case of tetralogy of Fallot and VSD, but it's like sporadic, not common, according to the center also. Okay, Dr. Buda, any other question you want to add or you want to ask?
Just for indication of surgery in aortic regurg, first thing
Yes.
is acute aortic regurg. This is the cause, maybe infective endocarditis on aortic dissection. So it's first indication of surgery in aortic regurg. Then symptomatic, as you said, then asymptomatic with any one of three. The ECG is a finding in echo in aortic ridge is a rule of 50. So if ejection fraction less than 50 or in the systolic diameter more than 50 millimeter. Okay,
Yes.
so it is rule of 50. So if any one of them resting ejection fraction less than 50 or in the systolic diameter of the left ventricle more than 50, it is dilatation. And that means that aortic ridge more severe, that causing dilatation more than 50. Or if you have another surgery, as in any valve disease, if already the patient will go bypass surgery or any cardiac surgery, any other valve replacement, they may, even if not have any of this category, they may replace it together because it may also progress after that. There is question also about the complication or what is the prognostic factor in what is the single thing you
Yes,
should monitor
you're right.
in aortic
Yes,
regurg.
correct.
It is the left ventricular
Probably,
function. Yes, ejection fraction and the systolic in the systolic diameter.
yes,
Okay.
correct.
Complication, as we know, all valve complications the same, like heart failure and angina, arrhythmia, and sudden death also, and other valve disease, as all the valve infective endocarditis prone to it, the same, yeah.
Yes, exactly. Okay, thank you, Dr. Aisha. Echo finding, as I said, and Dr. Aisha already specify what you are talking about. In any regurg, two criteria you have to mention: the ejection fraction and end diastolic diameter. So remember these numbers, as Dr. Aisha mentioned, rule of 100. Some mentors, they are saying 60 plus 40, but if you remember ejection fraction less than 50, it's okay. The in the systolic diameter also more than 50 millimeter, it's also okay. You can specify these characters only in the regurg, either mitral
60-40,
or
it is in
aortic.
mitral regurg.
Yes, yeah. But
Yes.
if you cannot remember, you can mention the same 50 and 50, but better to specify 60 and 40.
60-40 in mitral regurg.
Yes,
Less
60
than
and 40.
60 ejection fraction
Ejection
and
fraction,
more
exactly.
than 40 diameter of
Yes.
left ventricle. This is for mitral regurg criteria also the same of severity or replacement like that.
Okay. Any other question or suggestion? Dr. Marwa, your scenario? You can move.
40 years old female patient with normal speech. Please examine head and face for cranial nerves.
Sorry, I can't hear you. Can you raise your voice?
40 years old female patient with abnormal speech. Examine head and face for cranial nerve examination.
Okay. Here you go, Dr. Maida. Dr. Maida. Sorry, she's mute. Dr. Maida, can you unmute yourself?
I'm talking and
Yeah, I expected. Okay.
okay. Hello and
Ready?
welcome. Yes, ready. Okay, hi.
Hi.
Hi. My name is Dr. Maida. I want to examine you, and if it's that okay.
Okay, doctor.
Okay. So first I will clean my hands, and then if you have any pain or anything, just let me know, okay?
Okay.
Okay. So I will start examination first. The patient have abnormal speech. I want to talk to the patient if there is any slurred of speech or any abnormal type of speech. When it's
Yes, there's
how are you?
there's a scanning speech.
Scan and speech. Okay. Then I will start by. Okay.
You will also observe the head tremor when you look to the patient.
Tremor of head. And scanty speech.
Yes.
Okay. Then okay. I will ask this patient with this scanty speech. First, I examine the eye examination. I'll start with eye examination, examine for the second, third, and fourth cranial nerves, and sixth cranial nerve by asking the patient eye movement. If there is any diplopia.
Yes.
Mm-hmm.
Yeah, you will notice nystagmus in all direction of movement, and the patient also complaining for abnormal vision in all directions.
On all direction. Okay, I will ask the examiner. I offer if I can do fundoscopy for the patient.
Okay, normal fantasies.
Okay. Then I will go to examine the. I will start to examine the 7th cranial nerve.
Okay.
Okay. Then I ask the patient to clench first by closing her eyes and don't let me open her eyes. Then by bowing of her cheek, show me your tongue. Show me your tongue and teeth.
And all are normal.
Okay. Then I will examine for the if there is I will just examine for the 8th cranial nerve by just I don't know how to say it. Okay, ask just if the patient have any abnormal hearing or anything.
Normal hearing in both ears.
Then I examine this 9th cranial nerve. I ask the patient to protrude her tongue and say ah.
Normal finding, normal uvula.
Okay. No deviation in uvula.
No.
Okay. Then I will examine the 11th cranial nerve by just the examination of the shoulder.
Normal.
Okay.
Normal bowel.
Okay. Then so the only positive thing that she has is scanty speech.
Yes.
And nodding of the neck, yeah.
Yes, nystagmus also.
Okay.
Nystagmus for abnormal vision on eye movement.
Okay. And okay, I didn't observe anything. I can't find anything. But okay. I don't know how to examine again.
You missed the trigeminal. Trigeminal.
Yeah. Try the trigeminal examination.
Olfactory. Olfactory, yes.
Okay, so I can examine the trigeminal nerve. I will examine for the three nerves of the trigeminal nerve. I start by the sensation around the eye and the mandibular part. If there is anything.
Normal sensation in 3 divisions.
Okay. I think I want to ask this patient to. I want to see the patient mobilize. Is that okay?
You want to the patient to move, yeah? To walk?
Yeah.
Yes, he has a taxi gait. She has a taxi gait.
Okay. Then I want to nose to finger test.
Yeah, your task is cranial nerve only. Cranial nerve examination.
Okay, just complete the task by if they allow it. Okay.
No. Hmm.
Okay, so I examined the cranial nerves.
Okay. Anything else you want to examine? Satisfied? Let's go to the auxiliary questions. Okay, Mama, you can
Okay, present your case.
Okay. A 30 years old lady presented with abnormal speech. Positive finding, there is a scanty speech. She had nystagmus all over in all the direction, and head nodding. I want to complete gait. She has a taxi gait. I want to complete my examination by looking for tremor. The presentation looks to me like there is many description for her, like dystonia, and also can be Parkinson or Parkinsonism.
What's your differential? You said Parkinson or?
Yeah, so neurological cause like Parkinsonism and Parkinsonism or Parkinson disease. I can put in my mind absent seizure. It can come with similar. Dystonia can be as well. Also, I can put in my mind TIA. It can be psychiatric causes as well, like catatonia. Also, I will put autism spectrum of disorder if I put psychiatric part of the disease. To complete my examination, also, I think I need a slit lamp examination because one of the differential diagnoses will be Wilson disease. I want to examine her thyroid. Maybe hypothyroidism can present it with similar case.
And do you think this patient has any cerebral affection?
Cerebellar, yes, with the ataxic gait and the nystagmus.
Yes. What type of cerebral? Type of ataxia? How can you differentiate between central and peripheral ataxia? In this case.
Peripheral and
Central and sensory.
I will ask the patient to close her eyes. If sensory, in the gait, she will have the abnormal gait while closing her eyes, this sensory. And if not, will be central.
From your finding, anything points to the cause if it is sensory or central from your as a finding in this case?
Nystagmus.
Yes, nystagmus and dysarthria.
Yeah, so this central.
If you want to examine other part, what will you examine?
I will examine the cerebellar symptom like nose finger test.
Yes. If you examine upper limb for, if you find this upper motor neural lesion, what will you think?
Mm-hmm. Upper motor. I will think about. I forget the name of the. It's in my mind, but I forget the name.
MS, you mean?
No, not MS. MS one of the differential diagnoses, by the way. MS is one of the differential diagnoses. I forget the name. Okay.
Yeah.
Frederick, you mean ataxia?
Yeah. Refrigerated ataxia, yes.
Continue, Dr. Marwan.
Okay. If you examine and you find peripheral neuropathy, how you will think?
Yeah. So Friedreich ataxia.
Hmm.
This my
What
first.
other
Peripheral
most
neuropathy.
with ataxia? Peripheral neuropathy with ataxia. What is the most common cause?
Ataxia. I didn't remember.
Okay. How will you investigate the patient?
Actually, yeah. So general investigation. I will do also vitamins because also vitamin B12 deficiency can cause such symptoms with
Yes.
peripheral neuropathy and ataxia. So still, I need to do vitamin B12 and thiamine. All this can cause these symptoms. So it's will be apart from my investigation, blood investigation, and so the blood investigation will be CT, renal function, kidney function, the renal function and liver function. I will do vitamins because vitamin deficiencies like vitamin B12, thiamine deficiency, all this can cause such symptoms.
What imaging you want to do?
Okay, I will do MRI for the brain because it's cerebellar symptoms. Most probably MRI for the brain.
If the patient come with this presentation but in acute stage, and يعني is the same presentation but acute, what will be first?
CT scan.
Yes, toxicology hemorrhage. Okay. As I'm finished.
Okay. Thank you, Dr. Marwan. Dr. Maida, please can you comment, Dr. Marwan? now?
Yes, دي cerebellar syndrome symptoms عندها اللي هي الديسارثيا والسكاننج سبيتش والنستجماس بس only finding في الكريال نيرف examination. السيربرال syndrome either central or sensory. الموت characteristic للسنترال الديسارثيا والنستجماس. السنسوري تكون associated with peripheral
Dr. Marwan, you're talking about types of ataxia, not cerebellar syndrome. You are talking about types of ataxia, sensory or cerebellar or central. Yeah, okay, continue.
Yes, cerebellar syndrome is the central cause of this.
Exactly, yes.
Yes.
Continue.
But if we put differential يعني for the case we can put central and sensory. طيب الساينس اللي عليها الترانكال كان اللي هي الهيد تريمورز والسكانينج سبيتش واف يو برضه اكزامن فور باور والتون فايند هايبوتونيا. Also if we examine the upper limb for coordination will be impaired while the patient opening his eyes. السكاتوكاينيزيا والintention tremors والpast point will be impaired while the patient opening his eyes because it's central. But if sensory will impaired while the patient close his eyes. This is the difference for differentiation. Yeah. Also في السنسوري في السنسيشن يعني الاكزامينيشن سنسيشن الافكشن بتاع الدورسال كولوم والفايبريشن سنس والبوزيشن سنس will be affected في sensory ataxia. Sensory ataxia also have central cause و peripheral cause. في السنترال كوز بيبقى فيه affection للسباينال كولد نفسه في الدورسال كولوم في السباينال كولد، عشان كده هيبقى فيه affection في الفايبريشن سنس وفي البوزيشن سنس. لكن في البريفرال كوز بيبقى peripheral neuropathy. الموست كومن كوز لما بنلاقي سنسور اتاكسيا وبريفرال نيوروباثي اللي هو الكحول كونسومشن، وغالبا بتبقى كرونيك بريزنتيشن مش اكيوت. الاكيوت ميبي اللي هي الاسكيميا او الهيموريج او انفكشن. وبست انفستيجيشن في الاكيوت السي تي زي ما الدكتوره قالت عشان اكسكلود الهيموريج، والكرونيك البيست انفستيجيشن الام ار اي عشان اني ديميلينيشن يبان احسن بيتر في الام ار اي.
Okay. So let's clarify the case, Dr. Marwa, as ataxia or cerebellar syndrome. Cerebellar syndrome, it can come.
Yes,
Yeah, it can come in this presentation, as you mentioned. Tremors.
Yes, this is cerebellar syndrome.
Exactly.
Central ataxia.
Exactly. So we are talking about cerebellar syndrome. Either, please take care while starting present the case. How old is this patient? So this 40s. Perfect. So you can put your differential according to the age initially. In this age, difficult to have a stroke, right? Particularly the ischemic one. Okay, you can have hypertensive hemorrhage, ICH, for example. So the most common presentation of the most common cause of cerebellar syndrome in such group of age may be the stroke, but the hemorrhagic type. The ischemic one will be an elderly patient or patient with comorbidity. Take care while starting giving differential. Give the differential according to the age. By the way, the age also is important in the previous case. We didn't talk about it. You have to specify some disease in the age, right? Like in the young patient, you have to mention the congenital before mentioning, for example, the sclerotic or degenerative disease, right? So how you can put differential makes sense. You have to put in your mind the age of the patient as a presentation. So let's go back to this scenario. In this scenario, patient with 40s, and he has cerebellar syndrome. If I will say stroke, I can say particularly the hemorrhagic one. What other cause of cerebellar syndrome in young patients? For example, if we assume the young female, what do you think, Dr. Maida? Sorry, Dr. Marwa, can you mute?
I will mute, okay.
Yes, please, sorry. Thank you. Dr. Maida?
Yeah.
What do you think if you have cerebellar syndrome with young female patient?
Multiple sclerosis in the first.
Perfect. Yeah, thank you. This is what I want to hear. What other cause of cerebellar syndrome in young patient?
One of them Friedreich ataxia.
Yes, perfect. Perfect. Yes, you have to mention. What other ataxic syndrome in young patient? Again, it's
Wilson can come with ataxia as well, yeah?
It's not common,
Very common,
but yeah, it's named as ataxia. Friedreich ataxia and spinocerebellar, right? Spinocerebellar ataxia syndrome. That one more we forget. So multiple sclerosis, Friedreich ataxia, spinocerebellar ataxia syndrome. Subacute combined could be. Sorry. Subacute combined degeneration is not affecting the cerebellum, right? Yes, you're right. It's not affecting the cerebellum. Subacute combined degeneration can present with all finding except cerebellar. So it's not fitting our differential.
Drug and infection.
Drugs, vitamin B12 deficiency, exactly, yes. And infection.
Cerebritis, one like encephalitis, yes.
Yeah, it's not common, but okay, you can put it in mind. But this is for the young patient or young. Trauma also can be. why not? Patient had trauma, for example, to his back or to his back of his head at the
And
area of
alcoholism also.
alcoholism. Yes, perfect. Okay, this is regarding the differential, and you can put in your mind again, if this patient is elderly, more than 60, what would be on the top of differential? Dr. Maida. The stroke, exactly, the stroke, and particularly the ischemic one.
Sorry, because
No
my
problem.
it's here.
Yeah, it's okay. How would be the presentation of cerebellar syndrome?
And paraneoplastic also would be
Paraneoplastic, okay, can be,
involved.
yes, can
Yeah.
be.
Or neoplasm even in cerebellum.
Cancers, yes.
Sorry?
Cancer.
Cancer, yes, already neoplasm mentioned, okay, in the elderly age. But in the top, as I said, stroke with ischemic one. Let's go to the manifestation patient would present with. Danish, remember Danish, okay? We have to memorize Danish like your name. If you have cerebellar syndrome, you have to search and look for these Danish letters. So D for dysdiadokinesia. You have to examine the hand, clapping of the hand. Ataxia. Ataxia either as if you can do it in the sitting, in the lying position. What you do? How can you do the ataxia?
Heel.
Yes, coordination test, right? Heel chin test. If you allow to make the patient walk, you will do the walking or the gait. The next is nystagmus. You have to do the H shape in all direction. And don't forget to do the upward one. If you have Parkinson and you suspect Parkinson, you have to do the upward gaze and the downward particularly for supranuclear palsy. But it's not the case. But I'm just reminding, whenever you do the H shape, remember to do in the midway or in the middle or the midline, upward and downward for supranuclear palsy.
Yeah, this is my question. Which one in Parkinson? Which type of nystagmus?
System atrophy, Parkinson plus cerebellum plus I think
Autonomic.
Which one?
autonomic, yes. Multi-system atrophy, yes.
Yeah. You mean associated with cerebellar? Yes, okay.
Yes, cerebellar, Parkinson plus autonomic, yes.
But don't forget the Parkinson tremors is different than these tremors. Bell rolling in the Parkinson, and in this patient, it would be intentional tremor. So you will ask him to handle or hold something. When he walk, the tremors will start. Intention tremor, right?
Yes.
But in Parkinson, it's bell rolling and it's unilateral. Okay, let's go to the next is standing or staccato speech, whatever you want to mention. You will ask him, please, can you repeat your name, full name, or for example, in our countries, Islamic countries, Bismillah ar-Rahman ar-Rahim, or anything you want to ask him to repeat after you. It would be staccato speech, alternating high and low, loudly talking. Okay, or this slurred speech or dysarthria. The last thing is hypotonia. You would do the tone either in the hand or in the lower limb. You should memorize this Danish for any cerebellar syndrome. Clear? Any question for this part as cerebellar syndrome? The causes, the manifestation already we mentioned?
The problem here is I need to know how to examine this case. We will start cranial by order. All the cranial nerve, all like Dr.
Better, yeah, better to start in order, Dr. Aisha. Why? Because
Not
you
to
might
forget and
yeah,
to
you
be
will forget.
systematic in front of examiner,
Exactly.
maybe.
Yeah.
And after that, we will doing the other things, the nystagmus and the
Nystagmus already
pointing.
there, Dr. Aisha. Nystagmus already there with the H shape. You will notice the
No,
nystagmus.
nystagmus is specific movement. We will not do
Lateral.
in all cranial nerve.
The H shape movement when you move to the lateral side, it would show you
Yes,
nystagmus.
but nystagmus should fix your finger first and move rapidly. It is specific test. We will do separately with the
While
bust
you are doing
pointing or no.
H shape, you will discover this
Yes,
nystagmus.
yes, it would
Mhm.
be there, Dr. Aish. Okay, when you move that to the
H
lateral
shape,
side,
we will not stop. We will not stop. It is just a movement of eye in all
but
direction. But nystagmus,
you will notice. Okay,
may
continue.
you should in nystagmus, you should fix and move fast. Fix and move fast. So you
What
will see
what
the
about the H
nystagmus
shape?
and
Okay,
fix.
what
And
about the
after
H shape?
moving fast, you will fix. H shape we will not fix. We just moving fastly in all direction. You should fix so you will notice the jumping.
No, while
No,
you are
I
moving
think
outward,
you will fix on the lateral to see and even diplopia. If you cannot
yeah.
fix, I think you cannot discover even diplopia. You fix to see if the nystagmus or diplopia.
It would be
Just
there,
you will
Dr.
ask
Aish.
diplopia by question. You will tell the patient if you feel pain or any double vision, please tell me.
Okay, this is by the
So
patient, and by yourself, notice the nystagmus. It would be clear. The eye will jump.
jumping will not notice till you fix for seconds.
But
Raj,
Okay,
while the
okay,
patient,
not we will not argue with this point, but
no, it's okay.
after the
We are
cranial
learning.
nerve, what we will do, we'll have time to do other tests.
So we'll try to do all the steps, but if you don't have time, you can say, I would like to do or to complete my examination by examining, for example, the tone, the gait, the speech, if you
No, I
didn't
know the
ask for the
bust
speech.
pointing uh, test and
Yeah,
coordination.
yes, perfect. Yes,
Excuse
the
me,
pulse
Dr.
pointing.
Aisha.
Yes,
In MS, if the patient has cerebellar syndrome and he has nodding, staccato speech, and he has nystagmus, this is typical cerebellar syndrome. We have to think about MS as a first possibility, of course, after stroke with hemorrhage in this age, and we have to look for 4 items in the eye. The intranuclear ophthalmoplegia, by doing the test of this and rapid relative afferent pupillary defect, we have to switch the light between eyes like this to detect rapid for MS and to ask for fundal examination for optic atrophy, for also to take the MS, besides the nystagmus. So this is 4 eye thing we have to detect in examination in cranial nerve.
see,
For this
Dr.
patient,
Goda, yeah, Dr. Goda added for you more steps to do. We are talking
for,
about cranial nerve, no time for
yes,
them.
yeah,
Yes,
yes,
I know.
only cranial. You have to invest in the second and eye examination. You have to
Yeah.
it's optic nerve and third, fourth, and sixth. Very carefully, we have to be examined to elicit the all item of MS because the
Yes,
patient
I agree.
has cerebellar ataxia.
I agree. Whenever you find patient with this presentation, you will suspect immediately MS, and you can add the specific test for MS. Yeah, I agree. But if you have the mentality, stable mentality to think and to remember the MS, it would be good to do other tests. That's why we are training. I added this session in our uh, session. I mean the short clinical case. Why? Because we are familiar with the communication, we are familiar with the long clinical, but the short, we are not familiar. Only during the course, clinical course, I mean, and maybe during the exam. Otherwise, the steps, the question, the discussion, we are not familiar with. I added this idea to be more familiar with the short clinical stage.
And
Doctor,
one of the question also
yeah,
about examination of the optic field, because it's important also in this case, if the patient has macular sparing or not macular sparing, you have to examine the field very good, especially the central part, because you will say this is most probably this is posterior cerebellar artery or this is the middle cerebellar artery, especially in this patient with the cerebellar attacks, it's a cerebellar syndrome. We have to examine the optic field. So the optic nerve should be examined light and should examine the field, should examine the acuity, should examine the movement for the nystagmus, and then the optic, then the fundal examination All this is important, especially this patient. Otherwise, the other nerves, trigeminal and official, and the other will be very fast.
Yes, yes. I agree with Dr. Goda, but again, it depends how are you familiar with these things. If you suspect MS, you have to do this test. If you suspect, for example, stroke, you have to do that other test. So it depends on your experience, how to pick up the diagnosis from your tests or from the steps of your examination. Okay, let's thank you, Dr. Goda, for this point added by you. We have to do this, by the way, if you suspect multiple sclerosis. INO, you have to do the INO test and you have to do the Marcus gun or the pupil examination as a reflex. Okay. Let's go back to Dr. Aisha question. How to do all these tests in 6 minutes? So if you suspect something, you have to specify or you have to direct your examination to your pathology. If you suspect stroke, you have to direct your question to or your examination steps to the stroke. If you suspect thyroid, of course you have to, but it's not the case here. Thyroid would be with the thyroid in the non-clinical. But by the way, I'm talking about the causes. Then what's important to do it in details, but it's if not important and not related to the case, try to make it fast, as Dr. Goda said. Regarding other nerves, what other nerves related to the cerebellum and it's important to examine in this scenario? As a stroke, I mean, I'm talking about stroke with cerebellar syndrome. What
I
cranial
think
nerve?
the cerebropontine angle
Perfect.
nervous.
Yes, exactly. These are the nerves you should examine, including what nerve?
Eight cranial nerve, I think.
Eight,
Or
exactly. Eight,
Eight,
four.
five, and
eight, 5, and 7, no?
7.
Exactly. Yeah. So what eight direct exam for eight?
Just I whistle like this in the patient's
Yes,
Whisper
by
ear.
your finger,
in the ear of the
whispering
patient.
or moving your finger beside the
Yeah.
ears. Do
Yes,
you
yes.
hear this? Yeah. If you hear this, and you have to close the other ear, by the way. You hear?
So eight,
Yes.
eight
Okay.
and the 7 only? Oh.
And
8,
fifth.
7, and 5 in the
Yeah, fifth.
ankle.
5 trigeminal is
Yes. The trigeminal sensation or the
sensation.
masseter, the bulk of the muscle of the face. The
Temporalis
masseter.
and this, yes.
Exactly.
Yes.
So if we are talking about stroke in elderly patient, remember already you are doing these steps, by the way, but you have to specify and to focus on these nerves. It might be there because of the stroke.
Oh, because this I asked about this question.
Yes.
Dr. Maida, I think she focused on what she think about. In exam, we better to focus on what we think, like if we find the patient already hemiplegic or something, we notice that he may be stroke. We will focus on these nerves, or we will also making systematic and start the cranial nerve by rule, so we can
For
focus
me,
on the eye more in the first thing.
yeah, my opinion, do it in order. 1, 2, 3, 4, 5th,
Because
6th, 7th.
also maybe we'll be hesitant in if we will think during the examination because no time. If we will think during the examination what we will do next, we will miss the time or
Yeah,
lose
this is
our
the
confidence.
exactly. That's why you have to train what to do and what order to do. In what order? First, you have to train yourself about cranial nerve examination. It comes in the basis recently. It came in many diets. That's why you have to train how to do in order from first till the 12th.
And fast also, not
Yes,
only in order, very fast.
the nerve you
Yeah.
think it is not related, not affected, try to make it very fast. The sensation you feel here, only one time. No need to make to go up and down. And compare to the chest. For example, this is for trigeminal. Okay, for the tongue
But here
movement.
you said that the fifth nerve also may be affected.
Yeah,
Fifth, I
Trigeminal.
that's
think,
why.
need sensation, facial sensation.
Yeah, the sensation. Yes, you will do fine touch over the cheeks, both sides. You will do
Compared
it
by
What
in
about 9,
comparison.
Dr.
P2.
Basim? 9, 9, 10. What about them?
9 and 10, uvula. Say open your mouth, say just open the torch, look quickly. If it would be deviated, you will see it.
And gag. I think gag.
Gag is not, no, don't do that gag. It's against welfare. Say, I would
only
like to do.
uvula movement.
Yes, uvula, yes. You can offer to do gagging, and you can offer corneal reflex. I would like to do corneal reflex. This is for fifth as well, fifth trigeminal, the sensation in the eye. Yeah, but it's not accepted as regarding the welfare, because it's very painful when you
It
do the
takes
gag.
time
But
also.
that's good. Will not do it. It's one of the
Yes.
steps, but will not do it. You will offer it to the examiner. Okay. I think we covered the most related topics.
For 11, I think just shoulder shrugging.
Yeah, shoulder or the neck. Shoulder is enough. For me, I will do the shoulder raise test. Some mentors or some videos showing also the sternomastoid. So turn your head against resistance here and here. But shoulder
For 12,
raise,
I think tongue movement on the
tongue
bilateral.
outside. Yeah,
Tongue
hybris.
outside and inside, also to push on the cheek, on the right, on the left, against the tongue.
This is for the power, yes, for the power. And
Yes.
yeah, protrude your tongue out to see if it is deviated, and the lesion will be directed by the tongue direction. So if the tongue is deviated to the right, so the lesion will be in the 12 cranial nerve in the right side. Curve, I mean the nuclei. Okay.
Yes.
Okay. Anything else? Yes. How to investigate? Again, as we mentioned, general, specific, bedside, and the imaging and the invasive. By the way, Dr. Marwa, I noticed the investigation presented by you in the previous case was disorganized. Let's do it now, and then I will do the about the second case investigation. For the aortic regurg, if we start by general investigation, what investigation will do? It's significant. All blood tests. Okay. Specific
General?
investigation. Yeah, general, all blood tests, CBC and chemistry and electrolyte. You can say all of them. It's general, baseline, basic test. What about a specific investigation? You mentioned already.
الإيكو والإي
No, this is bedside. That's why I tried to make it more organized. BMB, yes, BMB and
BMP.
BMB for heart failure and troponin.
Natriuretic peptide.
Yes, pronatriuretic peptide. Yes, this is a specific test for any cardiac patient. You will do this test, right?
But الإيكو برضو also for heart failure.
No, I know, but it's bedside test. If you make the steps of investigation like in this manner, general, specific, bedside. Now you can mention them in the bedside. Bedside test including ECG and echo. You can say it. Okay?
Yes.
Okay.
Yes.
For the infective endocarditis, you can add. I would like to do blood culture to rule out infective endocarditis. The image, chest X-ray. Okay, image, chest X-ray. And an invasive test, you can mention BCI, for example. If the patient is going for coronary angio, he can do a coronary, CT coronary, then he will do the percutaneous or cabbage, according to the case, I mean. But I mean, try to answer in organized way. General investigation, specific investigation, bedside investigation, imaging, and invasive test. Put it in your mind for every case, or follow your approach, but don't give haphazard investigation. Chest X-ray, echo, ECG, and troponin. No, try to specify what you are doing in a systematic way. Okay, let's go back to the second case, cerebellar syndrome. What test I will do in this patient? We'll start by general examination. Dr. Maida, the general investigation, what you want to do related to the case?
So general investigation apart from CBC, liver function, kidney function, I will do B12, thiamine.
Perfect. Yes. This, okay, we can say this is specific for the cause, right? You are looking for the cause by vitamin screening. What else specific related to the case.
MRI.
No, image, MRI for image. I want specific blood test.
B12 and thiamine deficiency.
Okay, what else? If you suspect in this patient stroke, ischemic one, what test you will do?
I will do ECG for AF and echo, this bedside
This
one.
is bedside. Oh yeah.
Troponin for and
No, not
Coagulation,
troponin.
coagulation profile.
Coagulation profile and one more. Specific test, lipid profile, thyroid function test.
yes.
You are looking for the cause. So this is a specific test. You will not do the thyroid function for every patient. You will do if you suspect something. You suspect here thyrotoxicosis or AF, for example. So I have to look for the cause and the signs and the investigation which could help me to relieve or to reveal the cause of the stroke. One of them, lipid profile, thyroid function test if the patient is AF. I have to do vitamin, as Dr. Maida said, vitamin deficiency or vitamin screening, vitamin B12. Okay, if you suspect genetic condition, what you will do as a specific genetic screening for exactly as for Friedreich ataxia or spinocerebellar syndrome, ataxia syndrome. Genetic screening. Bedside test, Dr. Maida, what you will do?
For this patient,
Yeah.
ECG for this patient to look for,
Perfect.
and echo as well.
Perfect.
Look for any thrombus in the ventricles.
Yes.
Yeah, this is the bedside one. I will do finger glucose for diabetes as well.
Perfect. Yes, you can do what any bedside test, VBG, for example. It's not significant here, but
Fundoscopy.
fundoscopy for okay for optic. You mean for multiple sclerosis, right?
For multiple sclerosis, I think it will not show anything, isn't
Optic
it?
neuritis. No, optic
It can show
neuritis.
neuritis if there is, yeah.
Yeah, pale optic disc. Okay. Now we'll go to the image. What test you will do or what image you will start with?
Okay. Also, this is according to if it's according to the age. I will start with CT scan,
Perfect.
acute or older age to exclude hemorrhage, and then I will do
Perfect.
MRI. This is the
Perfect.
specific.
Yes.
For
This is the way how to answer. I should do plain CT first to rule out hemorrhage. So particularly if there is lateralization or neurological deficit, I should do CT plain to rule out. But if nothing in the CT, what I will do MRI, as Dr. Maida said, or CT angio if you suspect stroke, ongoing stroke or evolving stroke. This is the way how to answer. Invasive tests, important in young female suspected to be having all this manifestation with hypotonia, weakness. What invasive test?
lumbar puncture.
Yes, perfect. For looking for
MS, no, for
Oligoclonal band.
oligoclonal bands. Exactly. Yes, exactly. Okay. The management. What do you think, Dr. Maida, the management would be?
according to the
Exactly. Treat the cause.
yeah, yeah.
Yeah, but don't
Vitamin-
forget multidisciplinary team, including the neurologist, the echo, the cardiologist, the thyroid, endocrinologist, uh, physiotherapist, very important. Physiotherapist, occupational therapist. Put them in the list. Always put them in your list. Physiotherapy and
Speech and
occupational
also
therapist.
therapy.
Perfect.
Yeah.
Speech and language therapy. SOL team. Thank you, Dr. Aisha. And treat the cause. Is it ischemic? So I will treat the coagulopathic or hypercoagulability state, for example, if there is. If there is thyroid, I will treat the thyroid. Admission, if the patient in acute state, yes, patient need to be admitted to monitor, to be observed. Neurological, some studies. Multiple sclerosis, I will treat the multiple sclerosis accordingly, acute or chronic. For the acute, steroid. So the examiner will take you to the topic he wants you to mention, whatever the cause. But in general, this is how to approach and to manage and to investigate. Clear both cases? Any question? Any comment? Okay. Uh, Hello? Hello, you can hear me?
Yes, now okay.
Yeah, I receive a call. Okay, any question before finish or ending the session? Some comments here. I will try to read quickly. It's shape enough. Yes, I guess. Hyperreflexia. Hyperreflexia, I agree if you suspect hypermotor neuron lesion, right? You have to do it. Heel to toe test, yes, it was for coordination for the ataxia. Vitamin B12 deficiency, subacute combined degeneration syndrome, not cerebellar exactly. It affects spinal cords and peripheral neuropathy. This is the difference between both. MF, Friedreich ataxia, post-trauma, alcohol, thank you. Not affect alcohol, also stroke, tumor, perfect. Dr. Aisha, multiple sclerosis, Friedreich ataxia. Dr. Aisha asked, tell us steps in examination of this case, please. Yes, we mentioned already and discuss everything. Any question? We have cocktail of cases today, cardio and neuro. But again, we would learn from this training as a way of discussion, as a way of to be more familiar with this condition. In the exam, you will have a lot of debates, what to do, what not to do, what to save your time with, and what to consume your time to do. You have to be familiar with the condition. Okay. By this training, you will be able to pick up the finding and to do what's related to the case specifically. This is the aim of this session. I know it's just imagination, simulation, but please consider it as a training how to be familiar with the discussion with the examiner and with the patient, how to talk, how to present yourself, how to introduce yourself to the patient, how to thank him at the end. Always keep thanking the patient, cover him. This is for the welfare. Wash your hands. All these steps you should do subconscious. You will not think what I will do now. Yes, I should clean my hands, so I will go to next what I will do now. No, you will go to the station. Subconscious, you will start all the steps. Within 6 minutes, you have to finish all the things. I hope all of you are learning from these sessions.
Actually, very important because for me personally, I forget about it. I'm like
Exactly.
I never do clinical at all, so I feel like I'm not here in this
Yeah,
part.
you will be more confident by this
Yeah,
discussion, by the way.
now, yeah, with the discussion and you understand, it become more. Thank you
Yes.
very much for
Most
this.
welcome, Dr. Maeda. Thank you to also for preparing and participating today. Anyone has question or comment before ending the session? Okay, see you tomorrow. If no more questions, we can end the session and see you tomorrow with long clinical day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Gode. Thank you too.
عليكم السلام ورحمة الله.
Thank you, Dr. Ahmed, as well.